Good day, everybody. My name is Raez. I'm the Chief Scientific Director, Chief Scientific Officer and Medical Director of Memorial Cancer Institute in Miami, Florida. Thanks to Grace, we are going to talk today about two new agents that were approved for lung cancer in the last 2 months. It's a very exciting time for us. And in the next video, we're going to talk about another two. It was amazing that in the last 3 months, we have 4 new agents approved for lung cancer. So we are going to talk today about Taletrectinib. This was approved for ROS1 tumors. And then we're going to talk about telisotuzumab vedotin. We call it Teliso-V. It's easier to pronounce. For metastatic, for MET-positive IHC tumors in patients with lung cancer. So we know when we talk about ROS inhibitors, I guess everybody has a lot of experience because we have been using ROS inhibitors for a while. Taletrectinib was approved in January 11, 2025 as the new agent, the new kid on the block. The standard of care so far until June this year is that what we can see here. No? So we have already in the market Ripotrectinib, Lorlatinib, Ceritinib, Crizotinib, Entrectinib. We start originally using Crizotinib first, then we move to Entrectinib. Really, Ceritinib and Lorlatinib don't have formal approvals, but we've been able to use it for many years. Finally, when Ripotrectinib came, it was very interesting because, as you can see, despite the fact that all of these agents were approved in different studies and we're not supposed to compare studies, but due to the fact that these patients are very uncommon, they have a very uncommon tumors, it's very hard to do randomized trials to compare all of these agents. So based on the information that we had about Ripotrectinib, we saw that the progression-free survival was 36 months. 36 months compared with the old standard of care Entrectinib, that the progression-free survival didn't reach 18 months. So based on that, because it's the only information available, and you're in front of the patient and you need to make a decision what is the best drug to give it. A lot of us are giving Ripo as the best drug based on this data. The toxicity profile is very similar, so the main decision is based on progression-free survival. But now Taletrectinib, the new one, is very interesting because the progression-free survival goes 1 more year. It's reaching the 40-something, 47, 48 months. So that's what it brings now the question, are we going to continue using Ripo as the preferred agent, or maybe we should move for Taletrectinib? If you're not familiar with information of Taletrectinib, there was a study called TRUST-2, and it has several cohorts. Today we're only talking about cohort 1 and cohort 2. These are for patients with metastatic non-small cell lung cancer that have the ROS1 fusion present, and they were randomized in 2 cohorts again, and for TKI naive patients, first line, or patients that already had previous TKIs, no? As you can see in the table, ROS1 patients are young, relatively young, or younger than the average lung cancer. These patients are in the 50s, compared with our average lung cancers are in the 70s. And there are females, non-smokers. The study, this drug is coming originally from Asia, so a lot of people from Asia was enrolled. And there were people with brain metastases because we know that these drugs work in the brain too. So these are the responses. The overall response rate on my left, on your left too, it was 85.2%. But if you add a stable disease, that are the columns in blue, you are reaching the 90s. So it's amazing. You have a drug that if you are a new patient with ROS1, it can work in maybe 90-something% of the patients. So in other words, very few people will fail. And that also happens in the brain. You see in the right, the overall response rate for brain metastasis is 66.7%. And then you can add the patient that in blue that had stable disease. That is also good. We call it clinical benefit. We not only look for overall response rate, that's what we report in these presentations. We also want clinical benefit because stable disease for an incurable patient is a meaningful clinical benefit. And then when we talk about responses in pre-treated patients, so meaning second line and beyond, The response rate, you can see in the left table, is 61.7% overall response rate. Plus, you see all of these patients in blue that had a stable disease. When you look in the right, the same happening in the brain. If you already are using taletrectinib in patients that have failed frontline therapy, you can still get a 56% response in the brain, plus some patients getting a stable disease. So that's why these numbers are very impressive, because we did not see these numbers in previous studies with other ROS1 inhibitors. Again, with a disclaimer that we usually are not supposed to compare, but again, this is the best clinical evidence that we have about these agents and these therapies. These are the progression-free survival. If you can see in B, letter B, very impressive, 45.6 months progression-free survival. Remember, with RIPO, we were in 36. Previously with entrectinib, we were in less than 18. So this is the longest progression-free survival that we have seen with a ROS inhibitor so far. So it's very appealing to us that maybe, you have a new patient, it's very, tempting to think of, these are the best numbers that we can offer to a patient that is new. And if you have treated patients, like in letter D, the progression-free survival is still 9.7 months. That doesn't sound too exciting, but unfortunately, that's what happens when you're in second, third, or fourth line. The progression-free survival is fast, it's short. So that's why, based on this information, you can make your own judgment how you're going to consider either taletrectinib in front line, or you prefer to stick to RIPO. One more caveat that maybe help you is one of the reasons why a lot of people are not very excited about ripotrectinib or entrectinib is about the CNS effects. Remember, with these agents, we get increased weight, we get dizziness, we get paresthesias in the hands, mood changes. And you can see here the CNS events with this drug are different from most of the other TKIs, like ripo, entrectinib, or even lorlatinib. And you can see the CNS events are really only dysgeusia and dizziness, and none of them are grade 3. So it's very interesting that now we are dealing with increased LFTs, in diarrhea, nausea, vomiting. I guess clinicians are a little bit more used to this management of these side effects than the management of CNS side effects. Because I remember when I did research for the other companies, when we presented these new agents in the past with CNS side effects, a lot of doctors are uncomfortable because they're not used to deal with the paresthesias, with the dizziness, and all of these things. But unfortunately, we need to accept that, because they were the only available agents. So now, if you have two options, one option is make your judgment between ripo and taletrectinib based on efficacy, or the second opportunity is you can make your judgment based on toxicity profile, which one is more convenient or less convenient for your patient, and then you can choose the best agent for the patient for frontline and reserve the other agent for second line.